most of you. I'm Riffin from Human Development, and I'm absolutely delighted to introduce today's speaker, Riffin. She received her BA from Mount Holyoke College in 2008, and then she was a research assistant at Brown Medical School. She's now a fourth-year student in our PhD program in Human Development, and like few other students, she's really pulling resources from all different corners. So she's involved with the BCTR, she's involved with Triple at Cornell, and of course also with Human Development. And she needs all those resources because she's interested in complex things. So broadly, her research revolves around interpersonal processes in chronic pain, caregiving, and other medical contexts and settings. And today she'll be speaking about part of her dissertation research, which is about joint decision-making in the context of chronic pain.
Just wait for Josh to come in, and then I'll get started.
Now we can start.
Our honored guest. So as Corinna mentioned, today I'm going to be talking about a pilot study that I've been working on as part of my dissertation research in conjunction with Weill Medical College, as well as some assistance from the Healthy Aging Lab here at Cornell. So first I'm just going to give a little bit of background about chronic non-cancer pain, because not all of us are so familiar with that area, as well as the various stakeholders that are involved in making treatment decisions for the patient. I'll then discuss how different social network theories, as well as theories of lifespan, motivation, and emotion, may also kind of offer some insight into why and how chronic non-cancer pain patients seek to involve other people in their decision-making processes. And then, based on that, next I'll describe a qualitative study, which is part of the dissertation, that we've been conducting and are actually in the process of still conducting to illustrate how these theories sort of align with the data that we've been collecting to date. I'll then conclude by offering some directions for future research, as well as implications for clinical practice. Chronic non-cancer pain is a widespread and debilitating illness for older adults, and the persistent nature of these conditions makes treatment planning a perennial issue. Over the course of illness, individuals need to contend with multiple treatment options and kind of weigh the risks of the pros and cons of each. Importantly, there may also be multiple stakeholders involved in the treatment process, including physicians, family members, and friends, other people who are there to support and guide the patient. However, there's really been little research to explore when and why individuals consult others during this decision-making process. Also unclear is the extent to which patients actually wish to involve others in their decisions around pain management, and it's also unclear when and whether these circumstances sort of differ across patients, whether or not they're undergoing surgery or just taking pain medication over the counter. Now, there's also considerable variation in the spectrum of preferences among patients. So whereas some individuals we can see here really rely on others in a paternalistic fashion, where the doctor might be making all of the decisions on behalf of the patient, other patients really wish to seek advice and involve others in this decision process, engage in much more of a transfer of information and knowledge. Still, others really prefer to manage their symptoms completely on their own, maybe through different remedies that they're trying or consulting media sources, things like that. Now, empirical research has linked several demographic characteristics with the desire for increased participation among older adults. So what we can see here is that female gender, higher education, better health, as well as younger age are all associated with increased preference for participation in health decisions. In addition to the level of desired involvement, it's also important to consider patients' choice of confidants. We know from research in other contexts that others certainly play a large role in the decision-making processes for those undergoing particular treatments. For example, health providers may be involved in a number of ways. As I mentioned earlier, they may take on an authoritative or paternalistic role when they're guiding patients toward making different decisions, or they may engage in much more of information transfer between themselves and the patient. In addition, family members have also been shown to play a pivotal role in the health experiences of older adults, particularly adult children and spouses who are heavily involved in their care. Friends have also been shown to be involved in the treatment-making processes by sort of a social sharing of their experiences and kind of bouncing ideas off of one another for different treatments and things like that. So in the following slides, I'll discuss certain factors that are important for the involvement of others. For example, ethnicity is an important factor to consider. And then I'll also turn to two theoretical models, social network theory as well as socioemotional selectivity theory, which will help guide and inform why these patients sort of turn to others. So here what we can see is cultural and ethnic factors distinguish the preference for individuals involving others in their treatment decisions, especially among Hispanics. So taking care of family members, or filismo, is especially important within these different cultures. It's actually viewed as a privilege and an honor. They're more likely to believe that relatives should care for and provide assistance to others. And they really rarely discuss treatment options with medical professionals. On the other hand, they might turn to curanderos or botanicos, who are sort of herbal remedy doctors, who are outside of sort of the Western medical system. Now, these are important factors to consider, given that chronic pain disproportionately affects Hispanics, both in disease severity as well as number afflicted. So therefore, our study employs this comparison of non-Hispanic whites versus Hispanics to uncover these systematic differences in the decisional processes and social preferences between each. Importantly, we're going to look at both informal and formal network systems where Hispanics sort of draw upon the informal guides versus the non-Hispanic whites. So in general, our study is actually guided by two theoretical frameworks, which provide insight into why and how networks are formed. First, I'd like to turn to social network theory, which offers insight into this issue. For example, strong ties are really for people where social network members share close emotional bonds. We can think of these as being family members and friends who are involved in the social sharing of the different illness patterns, versus weak ties who share a much more lower intensity connection, which crosses sociodemographic lines. These people are typically drawn upon for new resources and experiences, engaging in that information transfer that I talked about earlier for patients and their providers. Now, especially we can think of healthcare providers as providing access to new resources as well as information for patients involved in their care. So therefore, we believe that these two different types of ties might be important in informing patients' decisional preferences. In addition to social network theory, socioemotional selectivity theory also provides a framework for individuals' social and decisional preferences. And it proposes that there's a developmental shift across the lifespan from engaging in information seeking toward prioritizing emotionally salient goals. So this might help explain kind of why younger people might seek out more informational resources versus older adults who are much more focused on emotional regulation strategies. So we would believe that the oldest old might seek emotional partners who can really help them regulate their emotions versus the younger participants in our sample, and I'm really talking about the youngest old, who will draw upon people who would be able to provide them with more resources. So in other words, if health seeking is thought to result in negative consequences, the oldest old might seek less information so that they can therefore regulate their emotions better. In addition, decision-making itself is a very stressful experience, and therefore the oldest old might not want to waste cognitive resources on this issue. So all of these have implications for pain management. Now, the present study seeks to expand knowledge in the area of pain and decision-making. At the broadest level, we're going to look at when and why an older person might seek counsel or advice from particular others in their social network, with a particular emphasis on the following. First, the desired level of involvement in their treatment decisions, the factors that influence the choice of consultant, as well as the individual patient's preferences for the decision-making process and their treatment outcomes overall. Now, because this is an exploratory study, we don't hypothesize, we don't have concrete hypotheses, although we might expect that the younger individuals in our sample might reach out to social network members who might facilitate the acquisition of information versus the oldest old who might seek emotionally congruent partners. Also, given the strong emphasis of family solidarity within these Latino cultures, we might expect them to draw on more of the informal social networks, such as family members and friends, versus the non-Hispanic whites who might turn to their healthcare providers. Now, again, as I mentioned before, we're sort of still in the process of collecting these data, so it might be difficult for us to tease apart many of these associations, and we'll have next steps in the future, which will help us elucidate some of the findings that we're uncovering right now. So now I'd like to turn to our qualitative study, where I'll describe our study design and recruitment process. First of all, pervasive sampling occurred at 2 research sites in New York City. First was at the Wright Center outpatient practice at Weill Medical College. This is predominantly an upper middle class white sample that were recruited from this area, and then Casa Boricua Senior Center, which is a Latino center. And then with all of these individuals, semi-structured interviews were conducted to obtain qualitative data on whether and how these culturally diverse individuals go about making their treatment decisions and who they're involving. With regard to eligibility criteria, participants needed to be diagnosed with chronic non-cancer pain for at least 3 or more months, aged 55 and above, cognitively intact, and fluent in either English or Spanish. Our interview guide evolved through an iterative process, and here, although it says interviews were conducted from July 2013 to March 2014, that's actually incorrect. Interviews are still actually ongoing. We had expected to be done by this point, but we're still interviewing some of our Hispanic samples. Then interviews were transcribed and translated into English when they were conducted in Spanish. Data analysis is occurring in a 3-step process using the constant comparative method of analysis, where with line-by-line coding was initially employed to code participant statements into substantive categories. Next, we then sorted these categories and we compared them both within and across the interviews, and then we did this until no new categories emerged. So codes were then synthesized and collapsed into these central, or rather broader themes, so that we could create a systemized coding guide. And what we're planning to do with this coding guide is give these to 2 blind reviewers, and then so that then we can actually systematize our data analysis and have inter-rater reliability, which hasn't been calculated thus far. As we can see here, a data collection and analysis is occurring in an iterative process, just like our coding guide. So we're recruiting participants and then we're conducting interviews with these individuals. Meanwhile, our research assistants at the Healthy Aging Lab are translating and transcribing these interviews. We're coding interviews as they're coming in while we're continuing to enroll new participants and refining our coding guide as we're going along. All of this is in an effort to get to thematic saturation, or rather, when no new information has emerged. So that's sort of the goal of our study. Now, with regard to our results, first I'll just give a brief overview of our sample description thus far, noting the fact that we still haven't reached our final N, or what we assume will be our final N for the Hispanic group. I'll then discuss our salient themes, as I described before: level of desired involvement, choice of consultant, and reasons for involving others, as well as their perceptions for the decision-making process and outcomes overall. And when we have enough data available, I will discuss, some of these age differences as well as differences in ethnicities along the way. So overall, we screened 107 participants in the waiting rooms at these various places at Casa Boricua, as well as at the outpatient center at the Weill Medical College. Of these 107, 71 met our eligibility criteria, and currently we have interviewed 53, actually 54 as of this morning. But as I can, yes, so we're continuing to recruit, or continuing to interview, which is wonderful. Our research assistant was ill last week, so we're very excited to continue on with this portion. So as you can see, we have 75% entered of those who are eligible, but I just want to note that this number will only increase because we are still collecting data. With regard to our participants, you can see that we have somewhat fewer Hispanics than we do non-Hispanic whites. Their mean ages, we worked really hard to get these sort of comparable. They're close to being 70 years old. The non-Hispanic whites were a predominantly female sample, and Hispanics were kind of split 50-50 male-female, with the non-Hispanic whites being a little bit better educated than the Hispanics. I'm going to take a drink of water for a second. I'm also kind of dry. So now first, with regard to our findings and trends, we'll focus first on the level of desired involvement of these patients. Now first, I'd just like to point out the wide variability of patients' desired level of involvement in their treatment and in making the decisions with others. So as we can see on the left-hand side, this individual is saying, talk with as many people as you can. Get the good feedback and the bad, who's really engaging in an information transfer with others, versus the person on the right who says, who's going to tell me what to do? They're not the ones living in my body. So as we can see, some people are really valuing the joint decision-making process, whereas others are really wanting to manage their decisions on their own. Now, what I'd like to point out is along the way throughout the results section, I'll be referring to the patient's age, gender, and ethnicity sort of in this format as we move forward. Gender is distinguished by an F for female, M for male, ethnicity, W for white, and H for Hispanic. Now, we also sought to answer the question, who prefers more involvement? So the youngest olds in our sample said, I come in with a lot of questions. I don't just sort of take orders. I usually go in with a list and go down it. Again, this person is really seeking much more information than they had come in with, versus the oldest old saying, I've never refused a treatment that was offered. I figure the doctors know what they're doing. So again, consistent with empirical research, desired involvement really varied by age, such that younger participants engaged in this information transfer, whereas the oldest olds were seeking a much more passive role. In addition to the level of desired involvement, participants sought advice from a number or a variety of individuals for different reasons and through different time points throughout the illness trajectory. Now, these individuals overall, as you would expect, were medical professionals, specialists, rheumatologists, surgeons, people like that, family members, predominantly adult children and friends, and spouses, and then a separate group of friends. So in the next slides, I'll describe these different groups and when and why they were involved in the patient's care. Now first we'll just discuss the time course of involvement. So here, as you might expect, participants typically went to their medical providers first. However, across the board, it seemed that they were consulting all three groups about 50% of the time. Medical providers, family members, and friends were actually sought a little bit more than the rest of the groups. But it's also important to note here on this particular graph that these numbers don't add up to 100% because the categories were not mutually exclusive. So in other words, a given participant might seek advice from their medical provider, their family member such as a spouse as well as a friend. Now, from our analysis, we found that there were several reasons why individuals were turning to specific others. For example, instrumental support was really important for people to provide access to resources, such as rides to the doctor's office or help with filling out medical forms. Now, this type of support is a necessary component for the treatment process, especially in determining when and whether the treatment can actually occur. So people providing this type of support were really facilitating the course of treatment as a whole. With regard to emotional support, these individuals were really empathic listeners. Patients were turning to them for emotional or compassion and sympathy throughout the course of their trajectory. And then finally, informational support. Doctors might provide information as well as, family or friends if they have a background in medical knowledge. Now, because physicians are traditionally viewed as informational resources versus family and friends who are turned to for emotional and instrumental support, we might expect to see these patterns within our sample. And first, we'll turn to healthcare providers. Now, consistent with our projected differences, participants did turn to doctors for information. What we can see here, doctors should know, they've been trained to know. They have experience with lots of people with pain, so they know what works for other patients and what doesn't. Or, so another participant said, the doctor's the professional. I'm not the professional. So, of course, they were viewed as experts with a great understanding of pain, given their medical background and expertise. However, something that we didn't anticipate so much was that in addition to their role as authoritative experts, doctors were also turned to for their compassion and their emotional support. For example, the doctor at the clinic where I was going was really, really nice. I liked her. She was the kind of doctor that would put her arms around you. So you can really see this kind of compassionate care involved in a patient's visit to their treatment office. Still another one said, if you're hurting, you don't want to hear a lecture. You look for a bit of sympathy, just to have someone to listen to, again, referring back to their doctor. So when the provider was both empathetic and sympathetic to the patient's needs, they really felt supported in the decision-making process, which is something that I'll get back to later on in the talk. This was particularly important for our Hispanic sample, given that the role of cultural empathy was particularly important. For example, when I get there, my doctor receives me with a blessing, and he's not even my family. So we can really see from this Hispanic sample, it's kind of a poignant moment where he's not only getting the kind of treatment that he would like from the doctor, but he's also getting that compassionate care in terms of cultural specificity and empathy. In addition, the role of language was equally important for Hispanic participants. One said, when an American treats me that doesn't know Spanish, I get jumbled. I have to say here, there. I can't specify more because he doesn't understand. So even just having a provider who is able to offer services in that person's own language was important for this group. However, on the other hand, many patients, as we expected, many Hispanic people in our sample had a strong distrust of the medical system. It started with my mother. Then I watched my girlfriend die because of a doctor. I watched my baby sister die because of a doctor. I don't trust doctors. Or, my doctor's only interested in money. My doctor sent me to a specialist to clip my toenails. They clipped my toenails and charged me $20 and did nothing else. So again, we can see that cultural empathy is really important for this group. And when patients don't get the type of support that they need, and again, this is across both samples, not just particular to our Hispanic group, they were less happy with their interactions overall. For example, one participant said, it's very difficult to speak with any of the doctors. It's just too busy. The last time I was there were a lot of errors made. It concerns me. So again, especially when physicians had time constraints, were limited by time constraints, adding to this lapse of logistical lapses and errors, such as this lack of time, participants were really quite unhappy, displeased with their interactions overall. In addition, this other participant said, in my experience with doctors, they're just in and out, answer your questions and get out. So they weren't getting the overall empathetic understanding that they wished and desired. So with regard to that, patients did offer several pieces of advice for clinicians, most often describing the importance of personal and empathetic interactions, where they wanted to be talked to, but even more importantly, listened to. I won't read the first quotation because it's rather long, but in the second one, they're saying, I wish the doctor would listen to me and to what I'm saying. And then again, up on this first quotation, just to paraphrase, he's saying, I'm 86 and my wife is 20 years younger, and so the doctor's really speaking to her and not to him because they don't view that he's smart enough. He doesn't feel as though the doctor thinks that he's smart enough to listen. And now if we turn back to our Venn diagram I presented at the beginning of the section, we can see that providers were important for two reasons, for their informational support as well as emotional overall. So it became clear throughout the course of these interviews that providers' emotional and empathic interactions were quite important for the patient. And now I'd like to turn to family. Family members were also important for patients seeking advice, but for a variety of different reasons. Now, first and foremost, family members provided emotional support. My son has a way of understanding me. He knows where I'm coming from and how I feel. Again, within the context of larger decisions, such as knee replacements or joint replacements, family members became a critical source of support. My wife was with me when I had the knee replacement, gave me all kinds of emotional support. She's great. In particular, participants noted a spectrum of support versus pressure from family members. On the one hand, they felt pressured if they felt ordered to take a medication, which is what we can see on the far right, versus on the left-hand side. My husband was very supportive. He knew it was a decision I needed to make, and he didn't force me into it. He let me come to it on my own time. So again, as we'll see later on, feeling validated and supported is important for their satisfaction with their treatment as well as the outcomes, with their treatment process as well as the outcomes overall. Family members were also an important source of instrumental support. Discussing it with my husband, she's talking about her the decision to engage in a treatment. When to do it, how to arrange rides, but not in terms of questioning authority advice. So as I mentioned, instrumental support is a necessary component of the treatment process of when and whether to engage in the treatment and how this sort of shapes the overall progression of the course of treatment overall. So what we can see here is that family members fell neatly into both instrumental and emotional support. And then finally, I'll talk about our last group of individuals who are involved in the care of, in these decision-making processes, which are friends and non-kin companions. Friends are really there to share the social experience. So they've been through it. Doctors are trying to sell you on it. They cut you up and let you go, whereas friends have to live with the aftermath. So again, they're really engaging in this social sharing of the pain experience. And although we had expected that they would engage in that role of social sharing, participants also described how friends were actually quite a good deal source of information. Talking to friends is important because they can refer me to a doctor if I don't have a specialist in a particular area. Also, friends would then turn back to the people who are undergoing different treatments, for example, a knee replacement, to describe their own experiences and sort of solicit advice from the patients themselves. For example, a 71-year-old woman said, this fellow who just had his knee replaced asked me, "Do you think I'm doing the right thing?" I said, "I know it will be hard, but after you don't have to go through the agony with every step you take." So she was actually giving him advice after the experience that she went through. And so again, this sort of sharing of a shared experience was equally important. Especially important, which I didn't really expect to see, but that presented themselves as an individual group, were family and friends with medical knowledge, especially for our non-Hispanic white samples, where they were discussing their treatments with people who they wouldn't necessarily talk to, but these were non-kin companions who they might not discuss their pain with, but because of their medical background, they would then seek out advice from these individuals. So as we can see on the second quote, I have some friends who are physicians and specialists. I might send an email about a certain drug or a certain treatment to get advice that way. So even though these people weren't necessarily very close within their social circle, they might reach out to these individuals just in terms of pain care. On the other hand, for our Hispanic sample, they were reaching out to people who had knowledge of home remedies. For example, I talked with my daughter-in-law who's Dominican and knows a lot of home remedies, ointments for my knees. Again, in these other quotations that we can see here, they're drawing upon people who may have information about sort of home issues or things that are outside of the medical sphere, or traditional medicine. Again, patients would typically turn to friends for informational support as well as a little bit of emotional support, which is why we kind of shaded these two circles here in the Venn diagram. Now, just in summary, I'd like to point out kind of this spectrum of the individuals who are involved in their care in these in the decision-making process. For example, a healthcare provider might be a source of both emotional and informational support versus another healthcare provider who, yes, they might be providing them with access to resources and information, but they might not be as compassionate. Versus a spouse who would be located down on this bottom section of the graph to show that although they might be providing a good deal of emotional support, as evidenced by being on this side of the spectrum, they don't have quite as much information to provide. And then a friend with medical knowledge, again, might be somebody who is offering both informational and emotional support. Now, what we'd really want is for everybody to be in this top right-hand quadrant. Luckily, there's nobody down in the bottom left-hand quadrant, because what sort of information would that person be providing, and what source would they be of help in the decision-making process? Now, if we make this into a three-dimensional graph, we can see that a spouse, would be providing an extreme amount of instrumental support as well as emotional support, but again, being low on that on the informational support given. However, there were very specific reasons for why patients wouldn't involve anyone at all in the treatment decision-making process, as opposed to these people who are really engaging in that information transfer that I alluded to. For example, participants may want to preserve their own self-image. I'm a little leery of too many conversations about how do you feel. I listen and I decide on my own what sounds good, about what sounds good for me. In contrast, whereas preserving self-image is about managing impressions to others, self-efficacy has to do with a patient's own confidence in the ability to engage in treatment by themselves. So in other words, we can think of this distinction as being appearance versus skill set. They can handle this on their own. For example, nobody can help me but myself, or I make my own decisions. I can't be preoccupied with what other people say. Now, whereas the young old in our sample were more self-reliant in their information seeking, I know what to do, I look at myself, I look to my health as if it's my responsibility, versus the older people who did not have as much self-efficacy, who are saying, I don't want to make a decision myself. I'm not that smart. So that person would be much more likely to engage others in the treatment process versus the younger old saying, I know what I can do and I can manage this alone. In addition, we found that another subset of participants were saying that they wanted to protect others. They didn't want to burden friends, and they didn't. For example, there comes a point when you don't want to bother someone constantly, but when it gets really bad, or when my son asks me, I'll tell him what it's like. And then finally, not surprisingly, within this age group, some people just simply had no one to turn to. So nobody listens, but at least I put it out there, or I'm all on my own. If I'm lucky, I plead with him because he's the only person I have, referring to her son. So again, there was a spectrum of reasons for why individuals would not seek advice. And then finally, we'll turn to the final trend in our results, and this is actually the most important piece, which is the perceptions of the decision-making process overall, as well as the various outcomes. So what do patients really look for when they're making decisions? Well, in relation to their satisfaction came the empathic and personal qualities of others. For example, I had an excellent experience. The doctors were so caring, I couldn't believe it. It renewed my hope in the human race. Or, the doctor is very accessible, very easy to talk to. She takes her time with you and will discuss things. Again, this harkens back to these interpersonal qualities that are important for the decision-making process on the whole. On the other hand, if patients felt that they had no one to talk to or that nobody would listen, they felt unsupported in the process. Nobody listens, but at least I put it out there. Even though the doctors gave me the medications, usually the medications had side effects up the yazoo. I'm not satisfied with the doctor and his approach. I feel as though I'm not getting through to him. So when patients desire to be involved in the treatment process, they really want to be heard and listened to. Now, I'd like to turn to our outcome expectations, but before we can actually understand a patient's perceptions of their overall treatment outcomes, we need to understand what they expect. Many participants, especially those who were older and who had been involved in the treatment process for longer, were pretty resigned about the amount of pain relief that they would get. So I resigned a little bit to the way that it is. I don't have a great expectation that I will find a solution to it. I'm going to be 81 years old in a month, and there's nothing else I can do about the pain now. Again, treatment outcomes were contingent upon the patient's ability to find pain relief, but they were experiencing particular displeasure when there was sort of a mismatch between their expectations and the outcomes that they received. For instance, if a participant expected increased mobility after a joint replacement, but didn't achieve any greater function, they would be understandably pretty upset. This is in contrast with this middle person who's saying, who's already resigned about their expectations, and but then they said, we haven't really gotten any solutions, but that's the reality. That's not anyone's fault. So when they were in line, it was okay, and it was all right. They were still satisfied, versus somebody who is really frustrated because it doesn't seem that anything can be done or solved, and they had expected greater treatment gains than they were receiving. Now, this is sort of a worst-case scenario. If I had listened to my son, I wouldn't have had the surgery, but I was in pain and the doctor was about it. The day of the surgery, my son begged me not to do it. I kept telling him about the pain, and he said, okay, if that's the way you feel. From that day until now, I'm in a wheelchair. I cannot walk. And then I questioned why I couldn't walk. My son was right. All those surgeries were not necessary. So not only did this first person feel pressured by the doctor, by her son, she wasn't validated, she wasn't being listened to, and then the treatment ultimately failed. Versus a better case scenario with someone who said, I was not only pleased with the doctor's feedback, I was pleased that he was willing to do the surgery. In fact, I was encouraged to do it. Again, feeling validated and supported throughout the treatment process, and then feeling pleased with the feedback that they were getting overall. Now, in summary, overall, participants desired different levels of involvement, and they sought specific individuals for different types of support. For example, providers were most important for emotional and informational support, family members for emotional and instrumental support, and then friends for informational and emotional support. Again, younger participants did wish to engage in this information transfer and wanted to be involved in the treatment decision-making process versus our oldest recall the 86-year-old who said that he wanted the doctor to speak directly to him. They still wanted to feel validated and listened to, but they opted less into the treatment decision-making process overall. Again, cultural empathy was particularly important for our Hispanic sample. With regard to patient satisfaction with the overall process, as well as the outcomes, remember this concordance or versus a mismatch in the actual involvement or choice of consultants. When there was concordance between the two, they felt supported and validated, and they perceived the treatment to be much better, versus the mismatch between these treatment expectations and outcomes led to poor outcomes. And again, although patients might be frustrated with this ultimate outcome, if they felt validated and supported throughout and really got the desired level of support that they wished for, they had a more positive view of the treatment process overall. However, I'd just like to note several limitations, and we're going to expand upon this study. So this was a cross-sectional investigation. It was a small qualitative study with a limited sample size, and we were only able to examine 2 ethnic groups. However, with regard to our next steps, we're then going to draw from this pilot data to systematically investigate social networks and how they sort of affect the involvement of others in the decision-making process for these chronic pain patients. So we're going to expand this to more of a lifespan sample, continuing on with this emphasis on cultural diversity, as well as including survey methods to get at sort of a larger sample size. And we'll be able to use some of the information gleaned here to inform our predictor variables that we're going to use to systemize data analysis, as well as slightly tweaking our theoretical frameworks toward a different venue, given that in this area, socioemotional selectivity theory may not provide the best framework for this, given that there might be sort of, now I'm blanking on the word, cohort effect. Cohort effect in the two groups, even if they are only between the ages of 55 and 85 years old. However, this study does hold important clinical implications. First, it provides insight into how decisions fail or succeed, as evidenced by the mismatch in patients' desired versus actual involvement in the treatment process overall. It also offers valuable information for clinicians as to how social networks occur kind of behind the scenes, outside of the patient-provider interactions, and what's kind of going on in terms of the broader network as a whole and how that affects the patient's relationship with their provider and vice versa. So overall, our data will then be leveraged to develop interventions aimed at improving the decisional satisfaction for patients overall, as well as reducing their decisional conflict and enhancing their treatment satisfaction. So that's it, and thank you all. Thank you to our ISCA collaborators, our New York City collaborators, and to our funders. Yes.
That was great. I was just reading, and there was a JAMA issue that came out yesterday. It has a nice, actually, review of fibromyalgia.
Oh.
And which is probably one of the leading presenting problems as far as pain, chronic pain. It just occurred to me, I don't know how much information you get beyond the screening criteria to say, you know, that people had to be in chronic pain for a certain amount of time and so forth to get into this sample. But it strikes me that if you do a larger study, you'd want to know what the sort of diagnosis is.
Yeah, we actually did ask that question, and so we have that information. I haven't included it here, but that's a
fibromyalgia is a very different phenomenon than if someone has a bad knee and they have chronic pain in their knee and have knee surgery. It's a very different around the psychogenic issues and around how medical providers respond to people with fibromyalgia as opposed to something that's more concrete or diagnosable. So it seems like that might be seeing
and in fact with reviewers too, they sometimes have this issue with just talking about chronic pain as a larger issue as opposed to, you know, particularly focusing on arthritis or something like that. Also, we're going to get at more of the context of these different treatments that people are undergoing, because as I mentioned before, you know, somebody who's doing a joint replacement surgery might be very different from somebody who's, you know, doing this self-management. So we're going to explore, you know, how the context of the decisions themselves actually influence their outcomes. But that's I'm so glad that you brought that up, because it's a really good point. Yeah.
Your Hispanic applicant from the senior center, was there a clinic there, or you were just in the senior center?
No, it was just, this has actually been an issue for us. What we'd hope to do is actually get either 2 senior centers or 2 outpatient practices so that they'll look a little bit similar. The people in Casa Boricua are pretty lively and vibrant, and they tend to be a little bit younger, and we did have some site differences with that.
They were all people who had pain conditions and were seeing physicians for their pain, or were they estranged from?
Yeah, it's an interesting question. So there are pretty systematic differences, between these 2 samples, because at the right center, a lot of times they were actually being seen by the physician and going in for their pain. With the individuals from Casa Boricua, we're actually not sure.
Well, because you might not want to make statements about, like, skepticism of the medical establishment.
If you're not pulling them. That's a fair point. Yeah, it's a really good point. Yeah.
I can't remember, or perhaps you said it already, but for the subsequent study, just to follow up on both of those, are you going to focus on, say, people, for example, who are considering joint replacement, or
Yeah.
It would seem to me that would really strengthen things.
Yeah.
If there were people who were standardized by considering a treatment, and then who they talk to and what kind of...
Yeah, I'd like to actually focus on a joint replacement, and that's also in light of, Corinne and I are working with an honors student, Shayna Ratner, on her project, which will be a portion of this study, and that has to do with treatment expectations. And if they were all undergoing sort of a similar path, we do want to explore differences in, people who are undergoing different types of pain management versus surgeries, just to see these different levels of invasiveness and how that kind of contributes to people's projections. But I think that would be particularly important for her sample, to look at it.
But it also does seem like it needs to be people who have, at a minimum, sought medical help within a certain time frame.
Yeah.
Right, because otherwise...
Yeah. And so what
wouldn't have to be for surgery necessarily.
Yeah.
Would actually be treated for pain by a physician.
Yeah, what we've done is we've opened it up. We've just submitted the IRB to extend to the internal, Cornell Institute for, I think it's their internal medical associate. So we've extended it to that, and then the Columbia geriatrics practice. So we're hoping that by extending it to those two sites, then we'll be able to explore those options, and hopefully these will be people who would have, stronger medical diagnoses. The problem that we've had with Casa Boricua is that we're not exactly sure. These are people who are coming to us saying that they have a self-reported pain condition, but we're not exactly sure.
And it's not a one-on-one split, so there's some Hispanics that were recruited through WISE, right? And then there's Hispanics that are recruited through word of mouth and polling based on the categories, because we also had issues with they were relatively young.
Yeah.
So we
that was a major issue that we had.
Selectively stock out on the old.
Yeah.
Give an example of a son disagreeing with a doctor, and first of all, whether you found ways of finding out how people resolved conflicts even within the medical professionals, because sometimes you get different diagnoses, and then how does one make a choice?
Yeah, that's a really good question. I think, actually most of the people said that this decision is mine. Some people would have consulted multiple individuals, especially when there was that split between, a son and a doctor, and when there were sort of different perspectives on the treatment as a whole. But they said at the end of the day, I'm the one to make these decisions for myself, even if they were getting a lot of input from other people. So it wasn't typically, an adult child or somebody else who was making the ultimate decision. What I found interesting is, although we didn't include them in the sample, there were a couple of dyads that I ended up interviewing for one reason or another, and that was actually really interesting. The woman who I interviewed, one in particular, that at first I thought that she was just, her daughter just kind of wanted to sit in. But as it turned out, she'd actually had a stroke and was cognitively impaired, which is why we didn't end up including her. But it was interesting just to hear their dynamics and to see, this was a woman who said, I want the doctor to talk to me, and I'm the one who's making these decisions. But then the daughter said, no, well, I accompany you to all of these. And so I had to kind of grapple with that and then realize that, in my other interviews, there may have been similar dynamics in these dyads that just wasn't coming across. And then, people would often mention a third party of people going in, a confidant, accompanying them to a medical visit, which has been written about, in terms of triadic relationships. But it's interesting just to hear these discrepancies, which I wasn't able to systematically uncover, but that is something that's really interesting. Yeah.
Do you have reason to think that these trends will generalize beyond pain, or is there something different about pain?
Yeah, that's a really actually interesting and excellent question. what I would think is that it would expand to other chronic illnesses, not in acute settings, but perhaps diabetes. I actually just read an article on HIV, which strikingly was actually, sadly, but very similar to this study. And they said, HIV has now been conceptualized, instead of being an acute illness, it's now conceptualized as a chronic illness, which I haven't had much experience with, researching that area. So I was surprised to hear. And then, they described all of these different types of support that people were seeking out for their HIV issues, and it actually mapped on pretty well to our study, just in a different context. So I think it's important to look at, as people are getting older and our baby boom generation is developing these chronic illnesses, I think that perhaps this can be expanded and generalized, but I think it's kind of a neat area to explore, just because there is this spectrum of people who are undergoing very invasive treatments, surgeries that they're really not recovering from, versus people who are, just, taking pain medications or doing stretching or exercise on their own, taking dance classes to, help limber up. I have to say this because it's exciting. I got to interview a woman who danced on Broadway, and she was continuing to take tap dancing lessons, so I thought that was kind of cool. And that's how she was managing her pain, and she was 83 years old. So, but I do think that there will be kind of applicability to other areas. At least I hope so. I hope this isn't just, a chronic pain phenomenon, and that we can expand to other areas of research that's not in an acute setting. Yeah.
I'm just curious, as you go forward on this, are you going to continue, correctly you said this too, but with these purely qualitative designs, and this is just in the spirit of brainstorming, it seems like a lot of what you're looking at is not only quantifiable, but there are existing scales to measure, like positive and negative support from other associates, and I wonder why the choice, it's almost like you could move beyond being exploratory in a way, because there are instruments that measure a lot of the things that you're looking at. Are you going to continue though on the purely qualitative?
No.
approach?
So our next jump will be a survey study of about 200 individuals who are recruited from similar research sites in New York City and perhaps also here. But what we would hope to do is systematize, what we found here, and then, kind of ask the various, more standardized questions about these issues. Yeah.
Also, but I would like to interject in terms of, getting a more homogeneous type of decision that you're looking at. One way, of course, to get a relatively homogeneous sample, but it takes a long time to recruit in order to look at quantitative effects. That may be the problem. But Catherine had some really interesting ideas in terms of using vignettes that describe a certain pain scenario, and then looking at how people who do have chronic pain, but how would they handle this particular scenario to get some consistency, but then also be able to.
Well, thank you. That's